Hi guys, good evening and welcome again to these deliberations in Obstetrics and Gynecology. And we are all getting next ready, aren't we? And a lot of confusion and a lot of uh, moments where you're getting all worked up. But yes, this is the time when we'll start reading together once again, and we'll focus on the clinical part. Like we always say, that this is going to be a lot of clinical questions, and we're going to discuss so much that it's going to become a habit for you to answer clinical situations. Because ultimately what's going to happen, that whenever you're going to a clinic, you're going to see patients live, you're not going to see an MCQ. So get used to this, and this is how it's going to be for the rest of your lives. So don't get worked up unnecessarily. Okay, so in the series of these sessions which you're going to have with you, I'm starting with gynecology today, and we'll do obstetrics tomorrow. And yes, hello to everybody, Dr. Lulu and Dr. Vishal Mishra, everybody. We'll start right away and we'll see what all questions you have to discuss with us. All right, chalo. So we are starting with question number 1. A 30-year-old lady who is nulliparous presents to the physician with lower abdominal pain with severe dysmenorrhea and dyspareunia for 2 years, which are only transiently controlled with NSAIDs. Her menstrual cycles are regular with normal blood flow. On evaluation, pelvic ultrasounds are normal. Laparoscopy reveals powder burn lesions on bilateral tubes and on pouch of Douglas, which on histopathology reveals endometrial glands. Which of the following is the next step in management of this case? Now, we have made it amply clear that the more question is long, the easier the answers are going to be. So this is a full clinical situation of a woman who is having pain abdomen, and yes, we have already done a laparoscopy which is showing us powder burn lesions, and when there are powder burn lesions, we are already hinting that it is endometriosis. And when we done a biopsy, see, the best diagnosis of endometriosis is by laparoscopy, and there's no doubt about that. Now, how can you substantiate the diagnosis even better? You can do a biopsy of a lesion which you are suspecting to be having endometriosis, and that biopsy, if it shows you what? It shows you endometrial glands. Excuse me. So those endometrial glands, if they are having if they are engulfed by the macrophages, so what are we going to call them? Blood filled or hemosidrin laden macrophages. So the histopathology diagnosis, the hemosidrophages, okay, the hemosidrin laden macrophages. So if you see laparoscopy, that's a good answer. If you see laparoscopy plus histopathology showing hemosidrophages, then that is even better. All right. So now this is a young girl who is nulliparous, and she's got this hemosidrophages, and I mean, we know it's a case of endometriosis. What are you going to do first? So obviously the anti-tubercular therapy is not going to be part of this, and antibiotic therapy is not going to take care of things. Hysterectomy is totally contraindicated in a 30-year-old woman who's got endometriosis. Look, all of us should understand that endometriosis is going to stay all her menstrual life, not just her complete life, the menstrual life, because endometriosis because of high estrogens. So when there are high estrogens, she's going to have these glands going on proliferating wherever they are present, whether they're in the pouch of Douglas or in the ovary, they're going to go on proliferate. So when we have estrogen till the end of the menstrual life, that is till 50 years, she's going to have high estrogen. So endometriosis is going to continue proliferating off and on, and recurrences are going to come. So it's a fight. You know, she's going to be my patient ever since she's like 25, and she's going to be till 50, she's going to be my patient. She's going to come for me for pain relief, and I'm going to give her medical management or surgical management, but till 50 she's with me. Now, you understood that if a woman has endometriosis, which is because of high estrogens, when she becomes menopausal, she has relief. Now, after menopause, don't start HRT for such patients. If she has endometriosis, don't start HRT, because it's going to restart the endometriosis problems. So that was one point I thought I'll put in right now. Now, so hysterectomy, I was trying to tell you, why not hysterectomy as an option? Because we will say that hysterectomy is going to give a good relief, right? But can you do hysterectomy for a woman who is 30 and is nulliparous? So yes, if a woman comes to me at 45 and she's got very bad pain with endometriosis, maybe I'll think in terms of hysterectomy, but not right now. Okay, so this is definitely not the option here. High dose of estrogen is going to probably make her really bad, because that's the real cause of the endometriosis. So combined hormone contraceptives, that is COCPs, is my favorite treatment, is the choice also in this question. And I think I'm going to go with this answer, and that's the best management for a woman who's got severe pain, because the COCPs, the combined oral contraceptive pills, are going to make the cycles anovulatory. When the cycles are anovulatory, they're also painless. So that's why we say that the patient will be much better with the COCP. Then what else is the benefit? We all must remember COCP is a low estrogenic condition. It's a low estrogenic situation in the body. We are all giving low dose pills. So when we are giving low dose pills, then remember the basic funda of combined oral contraceptive pills. The basic fundamental is that we are giving combined pills in a dose which is very less, and these combined pills are going to have estrogen and progesterone. They're going to inhibit the FSH and LH of the pituitary, so there's going to be no follicular growth and no rupture of the follicle. So no follicular estrogen, no follicular progesterone. So the only estrogen and progesterone in the body is the pill which I'm giving, and the pill which I'm giving is a low dose. So please remember that combined oral contraceptive pills is a low estrogen situation of the body. So if I give a woman with endometriosis COCPs, she's going to have low amount of estrogen, and that is going to make sure that the proliferation of these endometrial glands is going to become extremely low. So yes, she's going to have much relief in endometriosis proliferation and in much relief in the pain. Also, COCP will give her regular cycles, if at all she has irregular cycles, but endometriosis generally does not have irregular cycles. The main problem is the pain and the progressive, congestive dysmenorrhea which she is going to have every month. So yes, my best answer for this question is E, combined hormonal contraceptives or COCPs. All right, so what are you guys saying? Hi, artificial cycles. Yes, Naira Sheikh, I like your answer. Artificial cycles, that's why we say. If a family is completed, Meet Patel, you asked me a good question that if a woman, suppose this question was 30-year-old and she's para 2, life 2, why can't we do a hysterectomy? Yes, that's a very good question, Meet. You tell me, what is the importance of menstrual cycle in a lady? Meet, you really, mere dukti nerve pe tune haath laga diye. You really asking me something which is my favorite topic. Look, what is the importance of a menstrual cycle? Menstrual cycle is the completion of a physiology of a lady. No woman ever liked her menstruation, but you tell her that I'm going to do a hysterectomy to get rid of all the discomfort you have, she's going to hit you. All right, so a woman will want her menstrual cycle every month at the same time and in the same amount and the same number of days. Don't you know that women come to you in the OPD saying that, sir, I'm bleeding too much this time, it's 7 days this time, I don't like it. And don't you know women come to you saying that they are having periods only for 1 day this month? So if it is too much, they don't like it. If it's too less, they don't like it. They want it right amount, right number of days, and with not much of pain. So that is what is the completion of a physiology. Now she's been having it ever since 12 years of life, and she's now 30, and she's got 2 children. And you say, okay, you got endometriosis, I'm going to take out your uterus, and you're going to be fine, rid of all the problems. 95% of women, I'm telling you, they're not going to like you. They're going to say, I want my uterus, I want my completion of my physiology, and it's a sense of completion that I'm getting my periods. So no woman is going to be happy if you do a hysterectomy. Okay, yes, if it is so bad that she's getting, the pain is not relieved by any method and she's getting, psychotic because of pain, there are some conditions where we do end up doing hysterectomies. But as far as possible, hysterectomy is option only after 40, I would rather say after 45 years in a case of endometriosis. All right, so good question, and you really got me going for that one. Okay. So hey, we'll come to this question. Okay, chalo, most of you got the answers correct. You're asking me some other questions. We'll come back to those. Now, let's say question number 2. A 40-year-old lady presents with heavy menstrual bleeding to the physician for evaluation. Her cycles are regular, coming at intervals of 20 to 40 days, lasting for around 7 to 10 days with intermenstrual bleeding for the past 6 years. Medical management with tranexamic acid hormone therapy have only provided transient relief. She is nulliparous, a 40-year-old who is nulliparous and is currently not using any contraception. Urine pregnancy test is negative. She is a known diabetic for 10 years on oral hypoglycemics. On examination, she is obese with BMI of 30.5 and ultrasound reveals an endometrial thickness of 14 millimeters with normal myometrium and normal adnexa. Which of the following is the next best investigation for evaluating her menstrual complaints? Now, look here. If a woman is 40 and she's having cycles which are irregular, and it can be 20 days to 40 days interval. Irregular cycles, 40 years. So keep in your mind always, even before going for the answers for this question, 40 and beyond, these are the women who are going to get endometrial hyperplasia, endometrial cancer, they're going to get adenomyosis, they are also going to get endometritis, and around 45 to 50 they can get endometrial infections. So if a woman is having irregular bleeding between 40 to 50, if that is your MCQ, always the first thing I will examine the lady. First thing always is examine the woman, examine the local anatomy. If all anatomy is normal, if all anatomy is normal, what you can see in the OPD? In the OPD, you can only see the vulva, vagina, and the cervix. You cannot look inside the cervix and you cannot see the uterus in the OPD. So if on examination the lady is fine, then what we can do? We have to find out inside the uterus if something's wrong. So yes, next thing is the endometrial histopathological examination. So that's the next best thing which you're going to do for a lady who's got irregular cycles after 40 to 50 years. Now, don't say that I'm going to give hormones first. Don't say I'm going to do an ultrasound first. See, ultrasound is a good adjunctive investigation. Yes, along with your examination and your endometrial histopathology, you'll do an ultrasound to find out what's wrong. But that's not the first thing you're going to do. So first thing you're going to do in a woman who has got irregular cycles is to find out what's wrong in the endometrium, and then only you'll see, okay, if it is a case of hyperplasia without atypia, my progestérons are going to be of use. If it is a case of hyperplasia with atypia, I may do a hysterectomy because there's atypia and more chance of cancer. If it is endometrial cancer, I'll do a hysterectomy first, and then along with the hysterectomy, I'll take the lymph nodes, I'll take the fascia, and I'll take samples of the peritoneum and see what is the staging of this endometrial cancer and plan my further treatment. So depending on what I see, I may see that she's got endometritis, so all I have to give her is antibiotics. So depending on what I'm going to see in the endometrium, I'm going to do any major management. All right, otherwise I'm not going to do a management assuming ki bhai, let's try progesterones first, let's try some other treatment with combined pills first. Please, 40 to 50, first thing examine and then do a endometrial histopathology. Now, how do you do the endometrial histopathology? In the OPD, we can do a PEPL endometrial biopsy, and in the OPD, we can also do next thing. We can do in the OPD, you can do a PEPL endometrial biopsy. It is painless. It is just a very thin plastic pipe kind of instrument. You can easily do this. So this is done in the OPD without any pain. Or in the OT, you can do a DNC, which is more better called a fractional curettage. But if you say a DNC, it's just fair enough. And then you can, in the OT under anesthesia, you can do a hysteroscopic examination. So a hysteroscopic examination is the best method of assessing the endometrium. All right. So what are you going to do for this woman? Which of the following is the next best investigation for evaluating her menstrual complaints? So MRI, Doppler, hormonal profile, pap smear. Look, all of these can be done, but these are not the first things to be done. So we always say the first thing in a woman between 40 to 50, after ruling out local lesions like CA cervix, CA vulva, CA vagina, and polyps and vaginitis, vulvitis, all of these local things you rule out. If you don't see anything wrong, then go ahead and do a office endometrial biopsy. All right. So yes, we can do it by a endometrial aspirate also. Okay, so this PEPL endometrial biopsy is just that. Okay, what do? We have a uterus. In this, you have this endometrium growing like this, and in this, you will take a small piece of the endometrial tissue in the OPD itself. So that is what is known as a PEPL endometrial biopsy. All right, so look, what all you guys have been asking me. F is fine. First investigation TVS. No. Ben Carson. Dr. Ben Carson, hi, good evening. So if you're really Ben Carson, but if you're not, then it's a good name you kept. Good alibi. Okay, first investigation TVS, since UPT negative, then we should do endometrial biopsy. Okay, so first investigation is never a ultrasound, and I know why you're saying that, because many places these answers are given, but you should see the books which matter, things like Novak's Gynecology. It's very simple, PEPL endometrial biopsy or the office endometrial biopsy. I know this answer is given in many places, so let's just move out and remember what Dr. Vij said, because you're listening to me right now. All right, chalo. And because just now we have watched your lecture. What is which doubt, my friend Suhaib Rumi? Which doubt you have? You know, there's so many things. Suhaib, height of woman stops at puberty means start in menstrual cycle. Then how height increase? Because we see the height of woman increase after puberty. So hey, we are discussing endometrial. See, you're asking me a question which is good, but it is not in relevance with the question right now. That's why I probably ignored it. Okay, so don't get upset. We will discuss this also. Okay, we know that it's an important question. Okay, okay, fine. Maybe I'll take that before I get into the next question. So, Ben Carson, you think it should be first because it's of fibroids. Why? Fibroids cannot have endometrial hyperplasia. Fibroids cannot have. There are so many doctors who have done what you're saying, that I'll do an ultrasound first, and if it's a fibroid, that's the cause. So yes, go ahead and take out the fibroid, and you turn out to find, I mean, it turns out in that the patient in the histopathology has an endometrial cancer also, endometrial hyperplasia, and you didn't see that, and you did not take endometrial. Apart from doing the hysterectomy, you had to take lymph nodes also, and you had to take para-aortic and pelvic lymph nodes. So many doctors have burned their fingers who've done a hysterectomy straight away for a fibroid without doing a endometrial sampling. So yes, this is what happens if you are working day in and day out in the department, my buddy. So yes, I know it's going to be tough for you to change the way you're thinking, but then I'm going to go ahead and tell you to please examine, do endometrial sampling, go ahead and do an TVS. Who's saying you're not going to do? I'm going to do a TVS. Obviously, I'm going to do, but not as the first thing. Okay, right. Sound is not very good, dear. Can you just see what's wrong with the sound? They are not able to hear. If others are able to hear, fine. Can you please, students, tell us that if you're able to hear the sound? Otherwise, I'll just continue for the time being. Why, Hitesh? Everything is helpful for FMG. There's nothing which is going to be that FMG is going to be a lesser of an exam, and NEET PG is going to be a more tough exam. See, everything is going to be next now. So you're writing the same exam. Why are you even asking me this question? Maybe this exam on 30th of July might not be. So please listen to this lecture. If you're sitting and you're an FMG student, yes, most welcome. This is what is going to be the method of your exams very, very soon. So yes, please, all this already some 6-7 questions of your FMG exam have been solved. All right, chalo. Able to hear, sound is okay, fine. So somebody did not like my sound. I'm so sorry. You just check your mic of your phone, or you may change your device. That will help. Okay, chalo aage chalte hain. Okay, question number 3. A 26-year-old nulliparous lady presents to the infertility clinic for inability to conceive for the past 2 years. Her menstrual cycles are delayed, coming at intervals of 40 to 50 days, lasting 5 days with an average flow not associated with an average flow. This is not associated with any dysmenorrhea. Also, she's been taking treatment for acne since 1 year. So, irregular cycles, and she's also having some acne. Her husband is a healthy male of 28 years with no significant past history. And the ladies, I mean to say, her general physical and physical and pelvic examinations are unremarkable. Ultrasound suggests bilateral ovaries with multiple antral sized follicles. Which of the following laboratory profile is most likely to be seen in this patient? So yes, acne, irregular cycles, 26-year-old lady who is nulliparous with infertility. I know you have already made your mind. It is a case of a polycystic ovarian syndrome. So guys, can you tell me, before I go for this, which is the most common cause of infertility? Khulla question. I mean, it's that big question which is going to come in exams. Which is the most common cause of infertility? Men, women, all put together. Yes? Let's see what you guys are answering before I solve this. Is anybody answering? Idiopathic. No, don't answer this question, guys. Don't give me the answer to this question. Question number 3, we are discussing still. I'm asking you, what is the most common cause of infertility? Yes. All right. Yes. The most common cause of infertility is, Swami says, is PCOS. Shalu Patel says anovulation. So, look, the better answer is physiological. There's something called physiological infertility. Delayed marriage is a. Abhishek, you're joking with me, right? Okay. It's like saying the best method of contraception is abstinence, which you're correct, but that's not the best method, isn't it? So infertility is because of delayed marriage. Okay. Okay. My classes, I crack the jokes, Abhishek. Okay. Okay. So not PID. We ovarian failure. No, no cardiogenic syndrome in both sexes. Come on, guys. So a lot of you are saying PCOS. Please, the most common cause of infertility is anovulation. Yes, one of the major causes of anovulation is PCOS. Anovulation, there are so many causes. It can be hyperprolactinemia, hyperthyroidism, hypothyroidism more than hyperthyroidism, and then it could be central causes, peripheral and central causes like hypothalamic. There could be pituitary causes, or they could be ovarian failure. So anovulation could be many reasons. So just don't say PCOS. PCOS is one of the most common causes of anovulation. I agree. So I would want you to say anovulation. So remember, anovulation is the most common cause of infertility and it is the most treatable cause of infertility. Okay, so we will stick to that. Fine. So if this is the case of PCOS, what are you going to say? You're going to do. So this profile, increased day 21 progesterone. So that's wrong, because progesterone is the one which is not happening because she is not ovulating, so there are no progesterones. Increase androgens, correct. Increase estrogen, okay. Decrease progesterone, maybe we'll keep it here, maybe this is looking good. Increase androgens and increase sex hormone binding globulin. So actually sex hormone binding globulin is normal or reduced because androgen production is very high, and because of high androgen production, the sex hormone binding globulin from the liver is going to bind to these androgens, and SHBG is going to be ultimately very low, and the free androgens will be very high. Because of a low sex hormone binding globulin, the liver cannot make so much of SHBG as much as androgens are there. So the SHBG is limited or low and the free androgens are high. That's what is the cause of the hirsutism and the acne and all that. So not the best answer here. And decreased LH, FSH, progesterone and estrogen, that is wrong. LH is high. So the LH FSH ratio, all of us know, is more than 3:1 classically in PCOS. Markedly increase androgens and progesterone. Increase androgens is fine, progesterone is not increased. So yes, the best answer to this question is B for Bombay. Increase androgens and estrogens and decrease progesterone. So that is clearly the best answer in this question, and I'm very happy that a lot of you got that correct. Yes. Volume is a little low, so if you can increase the volume, see what you can do. Okay. So okay, I'm not going to answer to your volume problems. Others are saying the volume is fine. So let's stop talking about the volume. Increase the volume of your speakers. So I think we'll stay and continue the way we are. Okay. So the answer to this question was that it's a case of PCOS. Anovulation is the most common cause of infertility, and people who have anovulation are most easily treated also. What are the most common causes of infertility in a man? Man will have oligospermia, azoospermia as the common cause, and also psychological and psychiatric causes, and psychological causes like the patient having erectile dysfunction, premature ejaculation and all that. Okay, chalo. Young girl, question number 4, guys. Again, finally, it causes, I don't know, Mohammed Imran, in a patient of PCOS with hirsutism, and I'm seeing this one. Let this go up a little. Yeah. A patient of PCOS with hirsutism, we are giving giving COCPs and anti-androgen. So why anti-androgen are given if LH is suppressed by the progesterone, and finally that is what is decreasing the androgen. See what happens that when you give COCPs, we are giving COCPs with the purpose of reducing the androgens also. You are correct, Dr. Imran, you are absolutely correct. We are giving COCPs and we are combining some oral contraceptive pills with anti-androgens also. So COCPs, you give progesterone, it reduces the LH, reduces the net amount of. So a lot of women who are just on combined pills do very well. In 7-8 months, you see the body androgens are now reduced. So 7-8 months later, the hair follicles which are growing, they will have lesser, they'll have the pilosebaceous unit will have lesser androgens, so the hair follicles become softer and thinner. So a lot of girls get better only with COCPs. Yes, that's a very good answer. Good, you know that. Now, I give anti-androgens because I want a faster and better treatment. Anti-androgens are much better treatment to a PCOS hyperandrogenism than just giving COCPs. So that's how it is. Okay, I mean, like if you have pain relief with paracetamol, then why give aceclofenac and why give diclofenac? So that's the kind of thing. So you're correct. I agree with you. All right. Chalo. Question number 7. A young girl 7 years of age is brought to the physician by a mother due to vaginal bleeding since 2 days. Young girl of 7 years. She's also got some breast tissue enlargement since a few months. On examination, there is breast enlargement and pubic hair both with Tanner stage 3. She's only 7, Tanner stage 3 breast, and the vagina is normally developed. There is no lesion or foreign body noted. Ultrasound reveals a normal uterus with a left ovarian hypoechoic solid mass measuring around 4.2 into 3 centimeters. Her FSH is low, LH is low, TSH is normal, alpha fetoprotein is normal, and serum inhibin is raised. Serum inhibin is raised. Which of the following is the most likely diagnosis? So, a young girl of 7 years is having a precocious puberty, and that precocious puberty, they are saying that she's got a normal body development, she's got a precocious breast, and she's got some bleeding also for the last 2 days. And she's 7 years only. So, this case of precocious puberty with an ovarian lesion. So, tell me that one cause which you've been taught very well, which causes a woman to have increased estrogens so early in life. So, yes, let's see what you guys are answering. So, question number 4. Did somebody said central precocious puberty? How can that be central, my friend? Because the patient has a lesion, right? Patient has a lesion. So, yes, most puberty which is precocious is idiopathic. Most common cause of precocious puberty is idiopathic. And now in this question, they have very straightforwardly they said that there is a lesion in the ovary and the girl is having precocious puberty and the serum inhibin is high. So, they can't ask you much straighter question that a woman is having. They are giving you a question, it's a clinical question, but they are asking you facts along with that. So, what is that part of the ovary which is going to make the estrogens? So, we know that the estrogens in the body are made by the granulosa cells. The granulosa cells are the sex cords. They make a woman a woman. Now, these sex cords will start working very fast and very efficiently when the girl becomes a pubertal girl and the estrogens increase and she starts having menstrual, the proliferation of the endometrium and menstrual cycles because the estrogens are getting high. Now, if these estrogens increase because of exogenous administration or having a tumor which is making more estrogens like a granulosa cell tumor, so endometrium is going to proliferate much earlier. So, granulosa cell tumors, yes, those who answered that, granulosa cell tumors will cause a woman to have this dysgerminoma of the ovary. This is not a, that's a germ cell tumor. Germ cell tumors and dysgerminoma is malignant. It's the most common germ cell malignancy. It's 45% of the germ cell malignancy is dysgerminoma. So, that is not presenting like this. It's a malignancy which could be benign or mostly it's a malignancy which is the most common germ cell malignancy. Yes, dysgerminoma has a malignant behavior. Some of them have a much benign kind of a behavior also, but most of them are having malignant behavior, dysgerminomas. Now, functional ovarian cyst will not come like this. Epithelial ovarian cyst will not present like this. Epithelial ovarian cyst, the most common ovarian cyst, yes, which is the most common ovarian tumor overall. If you say from all the types, the epithelial, the germ cell, the sex cord, all of these put together, which is the most common ovarian tumor? The most common ovarian tumor is the epithelial ovarian tumor. And in that, what is the most common ovarian tumor? The most common is the serous cystadenoma. So, when I say what is the most common ovarian tumor, we say serous cystadenoma. That is correct. Okay. So, but this patient is obviously having a granulosa cell tumor. Okay. Functional ovarian cysts. Functional ovarian cysts. What do you understand by a functional ovarian cyst? They are not neoplasm first of all, and the woman is perfectly doing normal. She's got no bodily side effects because of these follicular cyst, corpus luteal cyst, all right. They are not doing anything problematic in a woman's physiology. It's just that the woman is doing her normal function. She's ovulating, she's rupturing, but sometimes the follicle becomes little bigger than 3 centimeters. Generally what happens, follicles rupture like 15 to 20 millimeter size. It may rupture at 20-25 sometimes, but if it goes beyond 30 and does not rupture, we say it's cyst. Beyond 3 centimeters, it starts saying it's a cyst. So that's a functional ovarian cyst, all right. It's not a neoplasia. So corpus luteum also becomes cystic sometimes, and so does hemorrhagic cyst or a theca lutein cyst. So those are these, they are not going to cause any problems, all right. They are non-neoplastic ovarian cysts. All right. So yes, let's see what you guys are asking me about this one. Okay, teratoma is not the commonest germ cell tumor. All right, please. Teratoma is not. Okay, you must read your theory books, Shaw's if you want to read, or you want to read the Novak's Gynecology. Please, teratoma is the most common germ cell tumor. Okay, fine. The most common germ cell tumor is the teratoma. Now, teratoma is how many times benign? 90%. Only 10% of teratomas are malignant. So, most common germ cell tumor is the teratoma and the benign type, which is the benign cystic teratoma, also known as the dermoid. All right. So, teratoma is not the most common germ cell malignancy. Dysgeminoma is. Dr. Swami, I think you're trying to ask me which is the stable part of the menstrual cycle. The luteal phase is always stable. The follicular phase can be prolonged in any woman. So, after 14 days, the time after ovulation, the luteal phase is always stable. That is 14 days. The follicular phase can be long in anybody. Okay. Okay. A 36-year-old lady presents to the physician with foul-smelling vaginal discharge associated with dysuria. She is multiparous, sexually active and not using any contraception. On a speculum examination, there is mucopurulent discharge exuding from the endocervix, a hypertrophic cervix and cervical ectropy. Now, ectopy means ectropion. The cervix is not like this. Cervix is a little open like that. So, cervix is the uterus and the cervix, if it is a little open. So, we say ectropion or a ectopy. This is just the way people keep on using a terminology in gynecology, that we say cervical ectropy or cervical ectropion. Which of the following is the most likely associated organism? Now, if a patient is having foul smelling discharge associated with dysuria, I can think in terms of mucopurulent discharge also. So, the discharge can, let's say, maybe we can think of trichomoniasis. Now, if there is mucopurulent discharge and she's having a congested cervix and cervical ectropy, congestion. So, yes, it can be also a case of foul smelling discharge. So, yes, now foul smelling discharge, we can think in terms of Gardner vaginalis also, but not in syphilis. Syphilis will come with some lesions. Candida will come with a typical discharge of a Candida, will have a curly white discharge. So, Candida and Treponema is out, and a high possibility is of gonorrhea, because gonorrhea comes with mucopurulent cervicitis. Now, yes, it can be trichomoniasis, but trichomoniasis, I want more than just discharge. I want the kind of discharge. I want to see greenish yellow frothy discharge. In trichomoniasis, I want to see a greenish yellow and frothy discharge. So, if I have something like this, maybe I'll think of trichomoniasis. And Gardner vaginalis, I'll say just a creamy discharge. Yes, there is a patient who's got bacterial vaginosis, she'll have a fishy odor. So, it's not a very specific thing which is coming in this exam, in this question. So, she's multiparous, sexually active and not using any contraception. There is mucopurulent discharge from the endocervix, hypertrophic cervix and cervical ectropy. So, this is mucopurulent discharge. I would go more in favor of gonorrhea, because what is the most common cause of PID? So, if a woman has symptomatic PID, what is more common than trichomoniasis and bacterial vaginosis, all infections put together? So, if three choices A, B and E are looking like the more likely answers to this, then I would say which is more likely out of these three also. So, yes, most common OPD symptomatic, if a patient is symptomatic and coming to the OPD with symptoms, so then I would think in terms of gonorrhea as the most common cause. Yes, otherwise the most common overall most common cause of PID is chlamydia, but symptomatic, prevalence wise it is chlamydia, symptomatic it is gonorrhea. So I think I will go ahead and mark gonorrhea as the best answer here because of that mucopurulent cervicitis, and she'll have this fever also, and she'll have some amount of discharge, whereas in a case of chlamydia nothing like that will be there. Chlamydia is a indolent asymptomatic PID. So out of A, B and E, I would want to go with Neisseria gonorrhoeae, because see, trichomoniasis and bacterial vaginosis, we need those typical findings to answer, like clue cells for bacterial vaginosis and strawberry vagina for trichomoniasis, all that I want to see. So let's see what you guys are going to argue with me. Let's see, bring it on. Mucopurulent discharge is like mucopurulent. It might be grayish white along with some amount of this has got that musty odor, but you cannot say that it is a typical smell of gonorrhea. That kind of thing is not there, whereas there is a very fishy odor in the case of bacterial vaginosis. So the smell is not very. Endocervical is affected by chlamydia and gonorrhea. I don't know. Yes, most of you have got it correct, but no, I will not say trichomoniasis and Gardner vaginalis so confidently in this. All right. So let's go to question number 6. A 29-year-old lady presents to the emergency department with fever and acute lower abdominal pain since the last 2 days. She complains of having vaginal discharge and mild lower abdominal pain since a week, and now acute exacerbation for 2 days. Now she is febrile to 102 degree Fahrenheit, pulse rate is 110 and blood pressure is 100/70. On a biomanual examination, there is cervical motion tenderness with fullness and tenderness in the left adnexa. So yes, they are telling us about a lady who is having fever and pain abdomen, and on examination there is a cervical motion tenderness, that when you do a PV, then the cervix moves. Why is it causing pain? Because the uterus is inflamed. Because when you're moving the cervix, the uterus is also moving, and the peritoneum on the uterus is inflamed. That's why the movements of the cervix will cause movements of the uterus and pain. So cervical motion tenderness, adnexal tenderness and lower abdominal pain is the classical triad. We call it a clinical triad of PID. So that is, one is the pain abdomen, and then the cervical motion tenderness and the adnexal pain. Bimanual examination of cervical motion tenderness and pain in the left adnexa. These three are known as a clinical triad. With this clinical triad, mostly we diagnose PID. So I told you that we can diagnose PID with laparoscopy also if required, but I don't remember doing a laparoscopy just to diagnose a PID. Mostly how we diagnose PID? By the clinical symptoms. Yes, if I'm doing a laparoscopy and so many times I've seen that the uterus is congested, there is some mucopurulent discharge from the end of the fallopian tubes, I am very sure it is PID. So best diagnosis of PID, of course, laparoscopy. But how do you do diagnosis of PID in the OPD? By these three. This is the clinical triad. So yes, the woman is having a HB of 11 and a TLC of 21,000, and ultrasound shows a tubo-ovarian mass, ultrasound showing a tubo-ovarian mass and laparoscopy showing inflammation are the extended criteria. 2 are the extended criteria of PID. Extended criteria means 2, that is laparoscopic findings plus the ultrasound showing the tubo-ovarian mass. So these are the extended criteria. If they are there, then we are sure that it's a case of a PID. Now they're showing a tubo-ovarian mass. So this is the ovary here. Let me show another color. This is the ovary here, and this is probably a looking like, they are saying it's a tubo-ovarian mass. Okay, fine. So it could look like a ruptured follicle also to me, but then yes, it could be a tube also, although I cannot make out the architecture so well in this picture. But then yes, they are saying it's a tubo-ovarian mass. So that's a giveaway. So my answer to this is that this patient has PID. How to take care of it? Now she's not pregnant, so that's out. Laparotomy not so fast. Laparotomy should be done if the patient is not responding to my treatment. So it's not a bad choice, but not the best choice. So I'll keep it as a standby. If she's not responding, then I would think in terms of going ahead. Yes, so many times when there is sepsis in surgery, in gynae, we open, drain the tuberous abscess, give a lavage and put drains and come out and give her IV antibiotics. So yes, before all of this, Do you want to give a AZ and doxy in the OPD? Now, what is difference? You know, PID can be managed in the OPD, PID can be managed in patient. So, what is the distinction? The distinction is if the fever is more than 100.4 degree Fahrenheit, that is the criteria for admission. And if the fever reduces 99.5 and lesser, she can be discharged. So, 99.5 and lesser discharge and admit if it is more than 100.4 degree Fahrenheit. She's got 102 degree Fahrenheit. Now, that's pretty, I mean, established fever along with all the symptoms. It's a PID which you're going to take care in the hospital. So, hospitalize and give IV cefoxitin and doxycycline. Alpha fetoprotein CA, I mean, see, this is a case of any tuberous mass you want to like, yeah, let's rule out a cancer, you know. Yes, a 29-year-old having a cancer with these symptoms, unlikely. A 29-year-old having PID is more likely when she's sexually active rather than having a cancer. Yes, she can have a cancer, but then that is generally not the presentation. Cancers are mostly insidious. They'll not come with, they'll be quietly growing and they'll become very huge when a patient comes to us, especially which is if you're thinking of an ovarian cancer, they'll quietly keep growing and become huge, and the mass symptoms, the pressure symptoms bring us. So this is not a cancer. So I'm not going to think of doing all these investigations. I'll give her antibiotics. So yes, most of you got that correct. And let us see what are the antibiotics, treatment of PID regimes. I've given these 3 regimes. Mostly my favorite regime is taking her in the OPD and giving her, but here the patient has got a fever. So then we have to give the IV regimes. IV regimes, I've mentioned the 2 regimes here. We can give cefoxitin IV along with cefotetan, and we can give doxycycline IV or orally along with that. But we can also give another regime where we give clindamycin and ceftriaxone. Then follow up, of course, with oral doxycycline and oral clindamycin in the OPD. So, clindamycin substitute is metronidazole. So, please remember these questions also come in your exams in your medicine also. If a person is allergic to metronidazole, very rare, but if there is a problem with metronidazole, then what is the substitute? Think of clindamycin. So, these are regimes, I mean, I've mentioned them. Please say you'll have to, some mug up you have to do, and this is one of those things. Now, let's see what you guys are. Question number 7, we'll see later what you guys are asking me now. Azithromycin age. No, age has got nothing to do with that. I mean, like if she's got more age, what does it mean? She can have PID if she's 45, 50. Why? People are sexually active at that age and they can have PID. Mostly happens because of sexual exposure. So, she can have PID, and we can treat PID in any age with this. No, I will not say if she is high age, then give her azithromycin doxycycline tablets only. No, answer will stay with that high age also, the answer will stay as C. So, best answer for this question is C, hospitalize and start IV cefoxitin and doxycycline. Okay, if she does not respond, then only we think in laparotomy. So, question number 7, a 22-year-old lady presents to the physician clinic with complaints of foul smelling vaginal discharge since a month. She is unmarried, sexually inactive and frequently uses mind this, and frequently uses vaginal douching for hygiene. Examination reveals a homogeneous grey vaginal discharge coating the vaginal walls without any erythema. Which of the following is the most likely associated organism? So, complaints of foul smelling vaginal discharge since a month, and she is having vaginal, frequently using douching for hygiene. Grey vaginal discharge. Now, this is the one which you wanted to answer as Gardnerella vaginalis or bacterial vaginosis. So, if there is, what are the choices? Lactobacillus? No, that is not the answer. Lactobacillus is normal. Any woman will have lactobacillus in the vagina. That is a normal commensal, you know, that is a friendly vaginal bacteria. So, not lactobacillus. Gardnerella vaginalis is my diagnosis, not trichomoniasis. Candida, of course, different symptoms will be there, and chlamydia will not have any symptoms. So, yes, the only symptom of chlamydia you may see is that the patient is infertile. So, patient will not come with any pain or, you know, any discomfort or discharge in chlamydia. Here she is symptomatic, she has got this greyish vaginal discharge, and there is you know, this very significant history of washing the genitals too many times and douching. So, all of this too much of douching has been promoted in the media these days, and all of these are detrimental for hygiene of a lady, because washing too much using these products is going to make a wet moist vulva and vagina, that is going to predispose to more trouble, more infections. So try to avoid douching as much as possible. That's what I tell my patients. So this is straightforward Gardner vaginalis. Of course, clue cells and alkaline pH written, that Amsel's criteria would have been a much better information. So yes, most of you got that correct. So Amsel's diagnostic criteria is fishy vaginal odor, vaginal grayish discharge, and pH of more than 4.5. That is relatively lesser acidic, that is relatively alkaline, or frankly alkaline, that is more than 7. And microscopy reveals increased number of clue cells, absent leukocytes. This is what is important, absent leukocytes. See, clue cells all of you remember, but leukocytes are characteristically absent in the case of bacterial vaginosis, and absent lactobacilli also. Whiff test, that is addition of 10% KOH, gives a fishy amine-like odor. So 3 or more out of 5 is equal to diagnostic. All right. So now those who want, इसको screen को मेरी तरफ करना please. Yeah, I don't know if you can see, but that thing on the side, ये इसको कर दो मेरी तरफ. This is what I want you to see. Yeah, now I can see on my. It's okay. It's okay. I can see now. Thank you. Thank you. Thank you, my friend. Yes, I should move this side. Yeah, that's the side I should be moving. I was moving on the other side. So yes, if you feel that you want all of that together, this is the list which I have given you, and bacterial vaginosis, trichomoniasis and candidiasis all together you can see in this, and that is so many characteristics, features and the treatment and how you distinguish. So this is a slide I made for a class, and I feel that it's good information which all of you can see in your okay. Let's see if you want to see it better. Let me reduce the size a little bit. Can you see that? Yeah, I think still it is not coming. All right, I think we'll not waste much time on this. Let's move on. Question number 8. A 35-year-old woman who is para 2, live 2, A2, pregnant with amenorrhea since 4 months. After her children, she has after having her children, she's had 2 surgical abortions for unwanted pregnancies. So I already know where this is going. Para 2, live 2 and 2 abortions. Mind you, if I say para 2, live 2, she is not pregnant right now, all right? Till I write G, don't assume there is a G. So if a woman has delivered 2 children and both are live and she has 2 abortions, so she was pregnant 4 times, so she is para 2, live 2 and A2. So she was pregnant 4 times. If she was pregnant, then I would have written grada 5. Okay, now she is not pregnant, so I'm not writing that, okay? So please don't assume a woman to have a pregnancy always. And don't say that any woman having 2 children, what is the obstetric score? She's G3P2. No, she's not pregnant right now. Till she's pregnant, do not say G unnecessarily. All right. So she's para 2, live 2. She has taken progesterone tablets to induce a withdrawal bleed, and then a course of contraceptive pills for periods, but still has not menstruated. So a woman who is 35 and she's had 2 deliveries and 2 children, she's not menstruating now. So what happens that sometimes we say, okay, fine, maybe she's not ovulating, so that causes delayed periods. So give her some progesterone, because when she's not ovulating, there's no progesterone. So give her some high dose progesterone, and after 5 days, stop the progesterone. So that causes a withdrawal bleeding, and a lot of women will have annullatory women will respond, but they will respond to progesterones. Progesterone will cause a bleeding only if there is estrogen primed endometrium. So progesterone withdrawal. Progesterone withdrawal works only with a estrogen primed endometrium. So if she is making estrogens and the endometrium is proliferating and she is not having periods on time, then we can give a progesterone. So that's what we do in PCOS, a progesterone withdrawal. But here you've given progesterone withdrawal, it did not work. So maybe we thought, okay, fine, let us make an endometrium by estrogens, secrete the endometrium by progesterones, and then stop. So that is with combined pills we tried, okay? Estrogen, progesterone, both are there, proliferation, secretion, both should happen, and she should menstruate. Even with that, she is not menstruated. That means the endometrium is non-receptive to estrogen and progesterones. So that endometrium is probably a scarred, destroyed, fibrotic endometrium. So yes, pregnancy does, the test done many times is negative. A pelvic ultrasound fails to show any pathology. Some other hormonal tests came out to be normal in value. Some other hormonal tests means apart from pregnancy test, they have done some other tests also, which have come normal. Which of the following is the most appropriate next step in the management of this patient? See this, some other hormones have taken care of the LH and FSH. Okay, progesterone for withdrawal, that has already been done, so not to be done here. Some other hormones means LH and FSH has been done and beta HCG has come normal, and laparoscopy and hysteroscopy are the obvious two options. So when the uterus is not menstruating, we get into the uterus and see what is wrong. So we get into the uterus with a hysteroscope and look into the uteroscope what is wrong in the lining. So that is what is known as a hysteroscopy for ruling out this patient's Asherman syndrome, or confirming in this case, I am very sure she has an Asherman syndrome. Okay, so hysteroscopy is the best diagnosis, although you can also do an HSG. So best is hysteroscopy. The best diagnosis for Asherman syndrome is hysteroscopy, although an HSG will also show filling defects. HSG will also show filling defects, that is also good, but the best is a hysteroscopy. So what are you guys asking me now? Let's see. All right, thank you, Dr. Nazma, sweet of you. Samskar, Asherman syndrome, likely Asherman syndrome, hysteroscopy should be the answer. Ben Carson, thank you. All of you got it correct. If a patient has a history, Vinay Kumar, you're trying to say if she's had a history of PCOD after cure successfully, she can have, of course she can have pregnancies, obviously. Yes, she can have, Vinay Kumar, she will have a pregnancy in PCOS, why not? 22 years is the usual age when we get girls presenting with PCOS, or women who are married present to us with infertility. So she will have children, don't worry. A couple came with infertility of 2 years duration, presents to the infertility clinic for evaluation. The woman is 26 of age, has a history of delayed cycles, coming after 35-45 days with no dysmenorrhea. She has no history of thyroid disease. General examination is unremarkable, and ultrasound does not show any significant pathology. A hysterosalpingography done shows bilateral patent tubes. Which of the following is the next best test for evaluation of this patient? Now, this woman has delayed cycles, and sometimes delayed cycles comes in patients who have no ultrasound features. So yes, remember that a woman having delayed cycles, we always say if her cycles are regular, she is ovulatory. If a cycle is irregular, she is anovulatory. But remember this basic, at least for exams, 95% what I am saying is correct, this statement. If she is regular, she is ovulating. If she is irregular, she is probably not ovulating, and that is 95% correct. So if she is anovulating and she is not getting pregnant, we already have an answer. She is not ovulating, she is not getting pregnant. So what are you thinking? When a woman is anovulatory, what are you thinking? You're thinking of PCOS. So what are the criteria of PCOS? PCOS criteria is that she's anovulatory and she's got hyperandrogenism and she's got a ultrasound look, ultrasound features of PCOS. Now all of these three need not be there. Any two is PCOS. If all three is there, fine. There are 4 types of phenotypes of PCOS which we have discussed in the classes. So remember, if all 3 are there, that is the type 1, the type A or type 1 of PCOS phenotype. Otherwise, there are 3 more in which 2 of these are present. So please remember, even if there are 2 like anovulation and hyperandrogenism, that is enough to say PCOS. Now this woman does not have ultrasound features, she has delayed cycles. I'll think of anovulation. So if there is a woman who is likely having anovulation and the hysterosalpingography shows bilateral tubes, but she is not ovulating, how do I know she is not ovulating? So MRI pelvis is not the best. Day 2 LH and FSH may be a good answer. Serum testosterone may be a good answer. Anti-mullerian hormone, okay, delayed cycles. If she's having, she's 26 years, maybe later I can do an AMH also. If she's a 26-year-old lady and she's having delayed cycles, I'm thinking in terms of PCOS already, anovulation, and maybe AMH is high in these patients, but a basal AMH can be done, but not the best answer here. So maybe not, of course, we can do AMH, but not the best. Serum testosterone, LH and FSH estimation, and day 21 progesterone. 4 possible answers are there. AMH is not the best answer, definitely. So now, this woman, we are not thinking in terms of hyperandrogenism so far. So she is not presented with that. She's come to you with infertility and she's come to you with delayed cycles. We're thinking of PCOS. To confirm PCOS, we can do LH and FSH. So yes, LH and FSH is a good answer, but so is day 21 progesterone. Now out of these two, B and E, which one do you think is a better answer? Yes, tell me. Which one do you think? Yes, all of you know day 2 LH and FSH karna chahiye. LH and FSH should be more than 3:1. So that should be a good answer. See, do this. It's a straightforward answer. So B and E. Let's see. Let's do this. Okay, no features hyperandrogenism mentioned. So hormonal tests are to be assessed. Okay, Dr. Zainab, fine. B. Okay, a lot of you are saying B. But my best friend is Dr. Sayani Devnath here. Answer is obviously E. Now, don't kill me, guys. Come on, please. If a patient is having irregular cycles, we're thinking of anovulation. And in PCOS, LH and FSH ratio is increased. Not as a rule, guys. It may be there. So many PCOS patients have normal LH and FSH ratios, and there's no. If it is more than 3:1, it is characteristic of PCOS. It may be 2:1 in some PCOS. It may be just normal. Yes, even today I saw 3 patients who have PCOS and their LH and FSH are not 2:1 or 3:1. I'm talking about today. I mean, it's today's date. You can check in my OPD. I have some 3 new patients, and it's 12th of July, and I've seen 3 patients, and all these 3 patients who had PCOS, we did not see LH and FSH. Yes, it is characteristic if it is more than 3:1. Agreed, but it's not there in all patients. So that's where you guys got it wrong. But yes, a woman who is anovulatory will have anovulation. So day 21 progesterone, if it is more than 3 nanograms per ml, that is ovulation. So if it is less than that, then the woman is anovulatory. So to confirm that she is probably having PCOS, I will definitely do serum progesterone. I will also do an AMH. I will also do LH and FSH. So you are not wrong totally, but it's best marked answer which is going to give you the marks. So yes, those who said E are more correct than the others. Okay. So explain. That's what I was explaining so far. I think you'll have to understand. All right. So, Prajwal, best test ovulation is day 21 progesterone. Okay, it's a good test of ovulation. I will not say that it is the best. Okay, this answer is over. Question number 9, the answer is E. End of discussion about this question. That is over. Now, I just saw one statement by a student saying that the best test of ovulation is serum progesterone. It's one of the good tests. Now, what do we do in the OPD? We don't do serum progesterone for everybody. We should be doing. But if I want to check ovulation, then an ultrasound, a follicular monitoring tells me that yes, she is ovulating. Why? Because the follicle is growing bigger. And after 14 days, when you do the ultrasound, it is shrunk on the 16th day or the 17th day. Then we know that she ovulated around 14, 15 day. So we do every alternate day, we're doing ultrasound and seeing the follicle is growing, and then we see the follicle shrinks. That is ovulation. So in OPD, how do you check ovulation? That we do by a ultrasound. But even better than that, usually we do ultrasound to check ovulation, serum progesterone also. These are both good tests. But if seriously somebody is asking you what is the best test of ovulation, and if laparoscopy is given there as a choice, you put in a laparoscope and you see an ovary with a corpus luteum, there's nothing which comes closer to that. Having said that, do I do a laparoscopy for every woman for checking ovulation? I don't. So, depends on the question which is coming in the exam. The language is going to be very clear. I know your guidebooks may say this is the gold standard, this is the first test, this is the best test, and this is the gold standard. If you're going to read all that, you're going to be always confused. Remember, how do we check ovulation in the outpatient department? Ultrasound follicular monitoring. That is what is done day in, day out. It's not the gold standard, it's not the best. It is the usual test done for checking ovulation. Serum progesterone helps me check ovulation. But if they ask you the best test and laparoscopy is given there, go ahead and mark. Just like best test for PID diagnosis is laparoscopy again. But do we do it? We don't. We do mostly the clinical trial just now we discussed. All right. So be careful about that. Okay, so let's move and see question number 10. A 30-year-old para for life for woman has all normal deliveries. First one is in the hospital and rest 3 with domiciliary. That means maybe in the house or in the village, conducted by midwives like that. She presented with some mass descending per vaginum. She is 38 years and mass descending per vaginum. On examination, there is a cervix descent of the uterus and cervixes up to the level of the introitus. There is no associated urinary bowels complaints. Which of the following is the most likely pathogenesis of such a presentation? Cervical elongation is probably part of it. Weakness of the pelvic diagram is the best so far. Past pelvic fracture, no. Intrauterine mass can cause pelvic mass, abdominal mass, ascites can cause descent, can cause raised intra-abdominal pressure, can cause. So there are three right answers. I'm sorry, there are 3 right answers. But yes, if she's delivered, the most common cause of prolapse is abnormal conduct of labor. Okay, so that is the simplest thing. And she's had 3 domiciliary deliveries. So no doubt that our doctors can do better deliveries. Yes, I mean, okay, I know some traditional midwives are even smarter than the obstetricians, but please, we are all MBBS doctors and we are going to value our specialty more than all the other specialties. Please, I'm not saying, please don't degrade anybody's work in this world. Everybody who's doing their work, all the specialties are nice. But we are the best, aren't we? Because we are the MBBS doctors. So we should be confident about our specialty. So we are doing the best because we are scientifically reading about normal labor, and then we are conducting deliveries in the hospital, and we are managing the second stage actively, the third stage actively, and making sure a woman is given assistance in delivery so that they don't have prolapse later in life. So please, if a woman is delivered by an obstetrician 4 times and then she's having a prolapse, bad obstetrician. Otherwise, mostly an obstetrician who is going to do a delivery, the woman is going to have 5 deliveries also, she's not going to have a prolapse. All right. So that's, of course, there can be other reasons of prolapse also, like there is some inherent connective tissue disorders, there are some masses, there are some ascites, there is chronic cough, there are so many other causes. But the main cause of prolapse is abnormal conduct of labor. Abnormal conduct of labor. Okay. So yes, that's the answer to this question. Question number 11. A man presents to the infertility OPD for inability to have a child since 4 years of his marriage. After noting a normal physical makeup in the OPD, he is given a semen analysis for his basic workup. He is found to have severe oligoasthenozoospermia. Okay, there is oligospermia, there is asthenospermia. Okay. The infertility is generally what happens, we get in the OPD oligoasthenoteratozoospermia. We call it OATZ, O-A-T-Z. That's what I get. But this is oligoasthenozoospermia. There is no teratospermia so far in this patient. So the infertility specialist confidently informs the patient, despite the semen analysis, he can still have his own biological child with his own sperm using the INI-CET technique. Which are the following parameters in the semen analysis made the specialist confident of his treatment? So let us see here. All of you got that correct, isn't it? So yes, that is very important to understand, that if a patient is having a irregular, if a patient is having oligoasthenospermia, then even if few sperms are morphologically normal and they are alive, then even if he's got very low counts, he cannot probably have a sexual intercourse and impregnate his wife. He cannot give an IUI or IVF pregnancy also, because for IVF also per oocyte you need 1 lakh sperms, good motile sperms. So he's got very few sperms, then I can individually pick up the sperms and put them directly into the oocyte, and that is going to give a pregnancy. That is known as a ICSI pregnancy. So yes, for that the morphology should be good. Even theoretically, even if one morphologically normal sperm is there, that woman can have her husband giving their own biological child for this couple. All right, so that's the answer. This is the new semen analysis. Please do have a look, WHO 2021, and that is showing that some things have changed. The one in red have changed, the one in black are the same, these 3 are the same, the morphology and the total count and the pulses are the same. So WHO 21 says that morphology is still 4%. Of course, volume, concentration, total motility, active motility and vitality have changed. Please do have a look whenever you have time. Okay, please freeze it and you must remember this one. Okay. Question number 12. A 16-year-old girl presents to the clinic with complaints of abdominal pain for the last 2 years. She states that she frequently has cramps and lower abdominal pain that lasts for a few days, and she's usually at the same time every month. She has not attained menarche yet, and she has attained breast and pubic hair development at 12. On examination, she has moderately tender suprapubic mass. Which of the following is the most probable diagnosis? Now, this is what is a straightforward case where a 16-year-old girl is having periodic abdominal pain for the last 2 years, and she's got a suprapubic mass, but she's also got breast and pubic hair development. So yes, somebody was asking me about puberty. So when I say delayed puberty, when is it? We say no periods till 13 years. That is what is delayed puberty. Now, if a person has no periods till 13 but has pubic hair, then we can wait till 15 years. So at 15 years with pubic hair. With pubic hair, we can wait till 15 years to say delayed puberty. All right. So please remember 13 and 15. Don't say 14 and 16. That is outdated. Long time back that is all changed. Okay. So 13 and 50. Now, what is the difference of delayed puberty and primary amenorrhea? What is the definition of primary amenorrhea? You know delayed puberty. What is primary amenorrhea? Quickly, let's see what you guys are going to answer. Come. Some of you might know that there's a hint already given here. Yes, come on, before you give me the answer to this one. Till 15. Primary amenorrhea, I'm asking you. Okay, 13, 15 is delayed puberty. What is primary amenorrhea? So nobody's answering. Look, guys, the problem is that when you and me speak, recurrent abortion, substitute, oh, guys, ovaries are not functioning, no menstruation till 16 years, no periods till 13, after 15, periods have never happened. See, look at your answers. All of you look at your answers. Now, I caught you live online. Each one of you, most of you at least. Guys, when I say delayed puberty, that is till 13 years. And when the person has pubic hair and not having periods, we wait till 15 years. What else is primary amenorrhea? This is primary amenorrhea, guys. This is primary amenorrhea. Only problem is that when doctors speak, we say primary amenorrhea. When laymen speak, they say delayed periods. Now, if somebody asks you delayed periods, you'll answer. If somebody asks you primary amenorrhea in the exam, you're all going to answer what you're answering right now. See, I caught you live. Please remember, we are always asking you primary amenorrhea in the exam. So it's not come for the last few years, this question. That's why you are escaping. But if they ask primary amenorrhea, you will say, yeah, we have read about delayed periods, but what is primary amenorrhea? It's all same. I know some of you, I'm very sure a lot of you got confused in this one. All right, if you got it correct, then I'm happy. So this is a case of imperforate hymen. Let's not waste too much time on that, because the uterus is going on getting bulged, because this hymen here, this hymen is blocked. It's a cannulation defect. It's not a Mullerian defect. Okay, so blood will accumulate in the vagina, it will accumulate in the uterus, and the uterus will slowly start increasing in size, and suprapubic mass can be felt. So this is a case of imperforate hymen, and the patient has hidden periods. So that is what is known as a cryptomenorrhea, all right. So yes, blood in the uterus is hematometra, blood in the vagina is hematocolpus, all right. Question number 13, an intrauterine device is a stress-free method of reversible contraception requiring single-time application followed by a relatively long period of contraception. All the following is a mechanism of action of IUCD except. So yes, impeding sperm transport, inhibiting their capacity, foreign body reaction in the endometrium, inhibition of ovulation, production of anti-sperm antibodies. Look, impeding sperm transport because cervical mucus is thick, because of, let's say, progesterone IUCD or levonorgestrel IUCD. So that will be correct answer. Foreign body reaction, all IUCDs have the foreign body reaction. So if the uterus has a foreign body here inside, the uterus is going to contract on this foreign body to expel the foreign body, the IUCD. So in that contraction, if embryo comes, that will also get expelled. So that is correct. Inhibition of ovulation, yes. Around 40% patients will have anovulation because of progesterone and levonorgestrel, because some systemic absorption. Yes, we know that when there is a progesterone IUCD, this is progesterone within the uterus. Okay, there is progesterone within the uterus only. It will have more local action, but this progesterone will have some systemic absorption also. So that progesterone will go and inhibit the LH and cause anovulation. But that is only 40%. But that is correct. So all of these are correct. And anti-sperm antibodies, no, they don't make anti-sperm antibodies. So we'll save it D. Question number 14. A 27-year-old, pardon the spelling, 27-year-old woman, para 1 live 1, presents to the physician complaining of heavy menstrual bleeding with cycles lasting 7 to 10 days. It is 7 to 10 days, guys, not 710. 7 to 10 days with heavy flow and passage of clots. Okay, that is basically heavy menstrual bleeding. She has not responded to oral tranexamic acid. A urine pregnancy test is negative. All the following may be tried with the least preference given to which of the following drugs. 27-year-old with heavy bleeding. We can call it menorrhagia or heavy menstrual bleeding. So we can give NSAIDs, we can give tranexamic acid, we can give estrogen, progesterone, so combination of estrogen, progesterones. We can also give androgens. We can give intrauterine devices with progesterones. So combined OCP, cyclical progesterones, levonorgestrel IUCD, endometrial ablation, that is after 40 years. Why? Because when I do endometrial ablation, ablation means this lining. Suppose this woman is having this endometrium which is bleeding too much. Every month she has a problem. Then next month I can put a microwave probe, and with a microwave probe I can burn the lining inside the uterus. That is what is known as the ablation of the endometrium. So when you burn the endometrium, it is scarred and it's not going to bleed again ever. So this is a permanent method, endometrial ablation. That's why it is done after 40 years, because it is permanent. It's a permanent amenorrhea. It's a permanent amenorrhea. All right. So yes, we will not do it for young girls like 27 years. All right. So that is correct answer. Most of you got it. A 20-year-old gravida 2 para 1 woman, a known case of fibroid uterus, presents to the gynecological department with acute pain in her abdomen associated with low grade fever for the last 3 days. So she's 20 and she's gravida 2. Okay, her CBC reveals a mild increase and she's in the 28th week of pregnancy. Abdominal examination shows a relaxed uterus which is larger than dates. Vaginal examination shows no leaking or bleeding per vaginum. So yes, she has a fibroid, she is pregnant and uterus will be larger, and now she's got acute abdominal pain, but the cervix is not dilated and there is no leaking. So they are trying to say she is not in labor, there is no leaking, but she has pain because she has a fibroid. So yes, it's obviously a case of fibroid. So first of all, no preterm labor. Torsion of fibroid may be very rare. Torsion of fibroid, I have seen around 5 cases, 6 cases maybe. Now recently I saw one. 5-6 cases in my whole career from 96 onwards. I'm in gynecology, and that too I've seen all non-pregnant patients. Yes, maybe one patient had, but that was doubtful. So yes, there was this patient whom we had to open because of pain abdomen, and the surgeon did a appendicectomy because of the pain which she had. But she was fine, and there was a fibroid which was very small. So I'm sure that was not the reason. The red degeneration of fibroid, yes, that's the most likely answer for the students who are writing this PG entrance exam or the EMCI exam. Infection in fibroid is not very common. Infection in fibroid is again very rare. So yes, the best answer is red degeneration. And the management of fibroid in pregnancy, please don't operate. If you operate a fibroid in pregnancy, she'll bleed. She's crazy amount of blood loss she's going to have. So please don't operate, give her conservative management. Okay. Question number 16. A 16-year-old girl presents in the gynecological outpatient department with the complaint of primary amenorrhea. On examination, she has normal breast development and no pubic hair. See, now I've made it as primary amenorrhea, not as delayed cycles. Okay, she has normal breast development and no pubic hair. Normal breast development and no pubic hair. Now, pubic hair, moment it comes in your discussion, think of androgen function. Androgen makes pubic hair in women, please, as simple as that. And androgen make pubic hair in men. So men have more androgens and more florid pubic hair, and women have limited pubic hair. Men have that diamond shaped pubic hair distribution. Women have a inverted triangle shape of pubic hair. But pubic hair in men and women both are because of androgens. So now when androgens are a problem, then pubic hair will not form. Androgens are very less, scant pubic hair might be given. So when pubic hair is there in the discussion, think of some intersex is going to be a question. On inguinal palpation, there are bilateral inguinal swellings. Ultrasound is ordered, which shows an absent uterus and the presence of bilateral inguinal masses, which is the most likely diagnosis. So yes, that's a man who's got undescended testes, and those testes are probably in the abdomen, and those are the ones which are not making androgens. The testes probably are having androgens which are not having a good function. Androgen insensitivity syndrome is the one which is going to present like this. But most patients who've got androgen insensitivity syndrome will have intra-abdominal testes. Intra-abdominal testes are most seen, but yes, they can also present as bilateral inguinal masses. So when people have bilateral inguinal masses, then we think in terms of patient having a testicular feminization syndrome. Now, testicular feminization syndrome is a normal looking, it's a normal looking woman, absolutely normal looking woman. She will not have any, if you look at her, you'll think that it's a pretty woman, but she is in fact a gentleman, because the person in the intrauterine life did not have the androgens working. So the distinction, when does the distinction of organs happen? The distinction of organ happens at 6 weeks of intrauterine life, and that time, if it is a boy, the androgen should be working to make a external genitalia look like a boy. If the androgens are not enough, then the genitalia starts to take shape of a female. So that's why it's a man with external female genital like a female, and will have the testes which aren't descended, because descent of the testes also requires the androgens. So here's a lot of testicular feminization syndrome which I've discussed very fast, but yes, that's how it is. It's a case of androgen insensitivity syndrome or the testicular feminization syndrome. All right, chalo. So that is an easy one. Yeah, Anam Sheikh, you got the way I teach in the classes. Yes, if two women who come with two girls who are sisters, they both come with not having periods, and one is a Mullerian agency and other is a testicular feminization. So if you do a karyotype of both of these, and then it comes out that this girl who's Mullerian genesis does not get periods because she's not having a uterus, but the other one, the testicular feminization, who's looking like a girl, is not having periods because that is actually a boy who's not having periods. So that's how I've taught sometimes in the classes, that what do you have to tell that first girl, that yes, the lady who's next to you, she is your brother or he is your sister. All right, so that's how we have some amount of small amount of fun in the classes. So thanks for remembering that, Dr. Sheikh. Let's move on. So question number 17. Yes, most of you got it correct. How will Turner present? Shahrukh, Turner will look like a short-statured lady and will not have breast development. Chest will be, always imagine any patient, the phenotype, as a person standing like this, hands like that, and this is the anatomical position of a human, and in a naked presentation. So this Turner syndrome phenotype, a short-statured lady with a webbing of the neck, low set hairline, and low set ears, and the patient will have a shield chest, no breast development, and a cubitus valgus, and that is not exactly a normal phenotype. But yes, what you can see else on an ultrasound, you'll see a short small uterus. Okay, so a 24 lady presents to the physician with complaints of being unable to conceive for 2 years. She is sexually active and has intercourse with her husband twice per week. The patient has stable vitals and general physical examination is unremarkable. A histosalpingograph of the patient shows beaded fallopian tubes with clubbing of the ampullary end. Which of the following is the most likely diagnosis? Now it's a case of infertility with beaded tubes and clubbing. Now this is what is very, very simple. A patient having beaded fallopian tubes and having clubbing at the ampullary end. So beaded and blocked tubes with calcific appearance, this is classical HSG of a patient who's got tuberculosis. So yes, they are trying to ask you what is the, remember tuberculosis always presents with tubal involvement in the pelvis first. So if there is pelvic TB, the tubes will be involved first. So beaded, calcific and rigid tubes with tobacco pouch heterosalpinx. So yes, the answer to this question is genital tuberculosis. All right. Now let's see the next question. An 31-year-old lady with irregular menstrual cycle and vaginal discharge is found to have a high-grade squamous intraepithelial lesion on pap smear. What is the next step? So yes, HGSIL, high-grade squamous intraepithelial lesion, or CIN3 like we say. So for the time being, what you've done a smear on the cervix. When you do a smear on the cervix, that smear on the cervix, when you see that on the microscope is showing you that the patient is having CIN3 high grade lesion. All right. So those cells are right now only on the surface which you've taken. When did you do a pap smear? When the cervix was looking normal to you. It's a screening test. Now that's a very, very important fact. All right. The pap smear is a screening test, and in that screening test you see the cervix is normal, then only do a smear. If the cervix had something hanging, then you would have done a biopsy. So when the cervix was apparently normal, you did a pap smear. Pap smear showed you abnormal cells like CN3 or high-grade squamous intraepithelial lesion. HGSIL means the same. Now, on the surface, you know all the cells are abnormal and it is high grade. Who knows, some cells are invading into the stroma. If they're invading into the stroma, how do you know? You'll have to take a biopsy. So how do you take a biopsy when everything is by your vision, normal vision, everything is looking normal to you? How to take a biopsy? You'll have to magnify your vision, and you magnify your vision with a colposcopic examination. So yes, the answer to this question number 18 is D, colposcopic biopsy. Good. Question number 19, a 55-year-old woman presents with abdominal distension, weight loss and anorexia. Ultrasound reveals bilateral ovarian malignancies with ascites. She has a history of breast cancer and is BRCA1 antigen positive. She is menopausal, nulliparous and uses oral contraceptive pills through most of her reproductive years. Her mother died of ovarian cancer. I mean, they cannot be, like, you have any doubt about this diagnosis? All of the following are known risk factors for developing ovarian cancer except family history of ovarian cancer. Use of contraceptive pills is known to reduce ovulations, and that is going to prevent ovarian cancer. So answer is obviously B for Bombay here. So nulliparity is because she's not going to have any break from ovulation. Multiple ovulation induction for infertility treatment, correct. That is also known to cause too many ovulations. So one thing you must remember, most common ovarian tumor again is the epithelium of the ovary. Epithelium, what happens every month? It ruptures. So if a woman is nulliparous, never pregnant, so she's rupturing more than others. Then a woman is having ovulation induction, let's say for IVF, more rupture. If she's having early menarche and late menopause, again more number of periods. So more cycles, more ovulation, more injuries. Epithelial injury causes ovarian cancers. Along with that, epithelial injuries, predisposition, familial history. Along with that, BRCA1 positive and gene positive. So all of these will give high chance of ovarian cancer. But what is protective? If I give combined pills to a lady for a long time, she's not going to ovulate. So COCPs are actually protective because epithelial injuries don't happen. So that one comes. Don't say OCPs cause ovarian cancer. So yes, that also. Ovulation induction for infertility treatment, a lot of you answered D. Look, IVF treatment, infertility treatment, multiple cycles. We say normally women should have 3 ovulation inductions, maybe 3 IUIs, and if she doesn't conceive, do IVF. 6 is what we use as a working principle. Now, a lot of people go up to 12 cycles and then do IVF. So, anybody having more than 12 cycles, some women say more than having 20 cycles, they will increase the risk of ovarian malignancies. But that is not a very straightforward, if she's had too many IVF, she will have ovarian cancer. She increased the risk more than the normal population, but that's not a straightforward risk. Okay, so yes, it is implicated. Infertility treatment is implicated. Okay, so yes, D is not the answer. The best answer here is B for Bombay. So the last question of the evening, guys. A young girl of 1 year presents with mass descending per vagina for last 3 years, and it's been progressively increasing in size. On examination, she seems to have a prolapse. Which of the following is not an appropriate operation? A young girl of 17 years. All right. This one is wrong, guys. I'm so sorry here. One girl of 17 years. Sorry for the mistake. Yes. So if a young girl, 17-year-old girl, has got prolapse, so the uterus is normal size, probably she's having a connective tissue disorder. So what we can do, we can pull the uterus inside. If you imagine, if you imagine okay, if this is my hand is the sacrum and this is the uterus, so the uterus is slipped out. So what you can do, you can take a rope, tie it to the uterus and pull it inside the body. Okay, the sacrum, this is the uterus. If it is slid out, then you can tie a rope and pull it inside and tie it to the sacrum, so that uterus doesn't go out. So that is what is a rope, tie to the uterus and pull it inside like a slingshot. So sling it inside the body. So take the uterus and take a tie on the back of the uterus and tie it to the sacrum here. Not as simple as that, but yes, we generally hitch it to the anterior longitudinal ligament in front of the sacrum and from the back of the cervix. That is what is known as a sling surgery. It is known as the abdominal cervicopexy. Now, if you tie it to the red one, if you say this is the, if you tie it to the sacrum, it is known as the Shirodkar. Now, if you tie it to the anterior superior iliac spine, so I'll change the color here and let's show you in blue. If tied to the anterior superior iliac spine, then we call it the khannas. And then if you tie it to the rectus sheath, let's see what color I'm going to use. Yes, if you tie it to the rectus sheath here, chat column please. If you tie it to the rectus sheath here, then that is going to be the Purandares. All right. So yes, Shirodkar, Khanna. Shirodkar I didn't write where it is the sacrum. Okay. So Shirodkar, Khanna, Purandare. So these are the three sling surgeries. Sling surgery is also known as the abdominal cervicopexy. Okay. So now when there is a sling surgery, we don't say Manchester repair as a sling surgery. Manchester repair is for women who are, let's say 25, 30, they've delivered 1 or 2 children and they're having a prolapse. So what we do in a Manchester, we pull up the uterus into the body, we tighten the ligaments and then we repair the floor. The repair of the pelvic floor along with tightening of the ligaments is what is known as the Manchester repair. All right. So Manchester is for a woman who wants to conserve a uterus. Along with that, she's got some pelvic floor weakness and she's got a prolapse and she's got some cervical elongation also. So Manchester, also known as the Fothergill repair, is for women who already delivered. So mostly, and young girls who got a complete uterus hanging out because of inherent connective tissue weakness, in there generally we do sling operation. These are not hard and fast rules. We have done sling for women who have just uterine descent and with not much of cystocele rectocele. We have done that. But what we are saying, the best is sling for nulliparous prolapse and Manchester Fothergill for young women who have 1 or 2 children, want to keep the uterus. So Manchester is for those women, and vaginal hysterectomy for women who are older than 50 years having prolapse. These are the set rules of the game. All right. So yes, amputation of the cervix is done in. So Chandani Keswani is correct. Amputation of cervix is done in Manchester. It's essential part. So we do a DNC, we do the amputation of the cervix, and then we do the Sturm-Dorf sutures, and then we also do the pelvic floor repair. All right. So yes, you're correct. We have to tighten the Meccan rods in front of the neo-cervix. Right, Rahil, thank you for your comments. Manchester, all right. Okay, so, right, I'm still here. So, we are into the, discussions of so many things which are having to happen in our next preparations. So PrepLadder is doing its bit for doing this. We are not preparing you for any particular exam which is coming now. We thought we'll just give you a lot of clinical questions today. Tomorrow we're going to meet for obstetrics. But the main idea behind all these exercises is to know that we are here to help you with more and more such sessions and give you the impetus which you need for solving your all clinical situations which are coming in the exams. And don't feel that you are in a new kind of a setup where everything is going to be strange. You know, we are still very much with you. You are still very much going to read the same topics and the clinical situations. So don't feel left out at all. All right. This is going to be the same life which you're going to have and the same set of topics which are going to be discussed. Let's see what you guys ask me about the questions. Mancha is done for menopausal. No, menopausal, why do you want to save the uterus? If it is hanging out, then we take out and repair the pelvic floor. Manchester means you have to tighten the ligaments and keep the uterus in place so that she can use it for another pregnancy. All right. So, right. FMG OBG के लिए क्या करें? Pets World यही पढ़ो, मेरी तरह पढ़ो, MTP. All right. अब मेरी तरह पढ़ो. ये कहते हैं ना कि जितना आप लोगों को पढ़ना है वही पढ़ना है जो पहले पढ़ते थे, पर अब मेरी तरह पढ़ो. क्यों? क्योंकि यही हम लोग आपको, we've been teaching you this from the very beginning, that you have to do clinical situations, and if you know the clinical situations, you can solve any MCQ. That's what I've been trying to teach you for the last 20 odd years. 2003 onwards I've been teaching. So we've been trying to tell you that whatever you see patients in your OPD as interns and in your life, clinical life, those situations come as exam questions. But yes, till now there were a lot of recall questions also. Which is longest, which is shortest, first to appear, last to disappear, the first presentation is this, last presentation is this. All of these questions are going to go in the background, and these kind of situations are going to come. So that's why we always said meri tarah padho. All right, chaliye. So you guys don't lose your confidence. It's going to be all of the same in a different kind of a method of asking. Right, guys, so we'll meet you tomorrow for the op session, and it was wonderful taking your comments while we were doing this, and I hope there was some noise, there were some big trucks moving in front of my studio because of the festival which is going on now, and God bless all people who are celebrating, but my soundproof studio also got some sound inside, so I started speaking a little loud at that moment, so I hope it was all muffled. Even otherwise, I hope I'm pardoned. All right, guys, see you tomorrow evening for the op sessions. Good evening. Bye-bye.